Device infection is a major medical problem. It occurs in up to 4% of people, depending on the population that you study. And when it happens, patients are hospitalized. They have to have their devices and systems removed with some serious risk associated with that, and then a new system implanted. They're often in hospital for weeks at a time, have courses of intravenous antibiotics, and very large healthcare expenditures related to that kind of care. Well, it's a very good question. When we designed the trial, we were looking at the prevalence of it in literature. And high-risk patients are defined usually as patients who have prolonged procedures, like a CRT implant, or they are having a second procedure, like an upgrade, revision, generator change. That population in the literature would have an infection rate in the order of about 2.5%. Estimates probably range between 1.5 and 4. And some evidence also that the rate of infection in general is going up. Part of that is because we're dealing with sicker patients with more comorbidities. The study design was a little bit complicated, so I think it's probably easiest first to talk about the design and how the trial worked, and the configuration of it, and the second is what the intervention was. First of all, if you have a rate of events that's 2%, you have to do a very large-scale trial to be able to answer the question. We assumed the rate would be 2% and that we would try to reduce that by 35%, so from 2% to 1.3%. That demanded the need to study about 11,000 patients. For us to do that, we thought the easiest thing to do was, in fact, to use something called a cluster crossover design. And what that does is that studies hospitals who deliver consistent care to a series of patients and then looks at their infection rate. So it collects data on infection in individual patients, but in fact, the unit of study, if you like, is in fact the hospital and its infection rate. So a hospital would deliver standard antibiotics, conventional antibiotics for 6 months, and then look at the outcome of those patients, and then they would cross over, and then they would give incremental antibiotics. And those incremental antibiotics would obviously have the intention to reduce infection rate. And as a result, you would then compare the infection rates during those 2 time periods. So each hospital did 2 conventional 6-month periods and 2 incremental 6-month periods. And then the sum of the trial then looked at the infection rate in 19,000 patients. The intervention, our standard guidelines now say to give people 1 gram of cefazolin prior to surgery. And the incremental therapy was the same thing, as well as vancomycin before their surgery. And then an antibacterial pocket wash with bacitracin during the procedure. And then 2 days of an oral cephalosporin after the procedure. There were 2 compelling findings that came out. Our primary hypothesis was to see how effective that incremental treatment was in the high-risk patients. Those were about 2/3 of the patients, and that reduced infection by 20%. That 20% reduction, the overall reduction was 22%, did not achieve statistical significance. The p-value was 0.1. We were obviously disappointed because we were looking for a very definitive result. We did look across a number of different populations to see whether there was evidence of a group that would benefit or something like that, and the benefit was remarkably uniform across males, females, across age groups, hospital sizes, diabetics, renal failure, etc. That kind of result suggests that, in fact, that moderate 20% reduction is probably real. But we did not achieve the goal of showing clear-cut superiority of the incremental regimen. The second thing that we found is that the infection rate was 1%. And if you recall, I previously said we were modeling on the assumption of 2%. And that 1%, in fact, was lower than our target in the very best case scenario. So it's somewhat rewarding to see that the infection rate's so low. It also means that our ability to be able to change that gets that much harder. So we actually did a little math and said if we were really trying to achieve something with a 1% infection rate, we need to study almost 50,000 patients, which is a difficult thing to make realistic. So in the end, I think it's rewarding that we executed the trial. This cluster design, actually, we analyzed it statistically a number of different ways, and we're not able to see that the design hurt us in any way in providing a good comparative population. So we had a good study design. The intervention made a lot of sense. It was simple and cheap and easy to deliver. Its effect was modest, and the infection rate's low. If you look at our 22% reduction in infection rate, you might, in some spheres, you might say, well, that's an important reduction. That reduction is that only applies because the event rate is so low. So if you do the math on that, it means you need to treat 500 patients to save 1 infection. And although that infection is catastrophic, you ask yourself, who would you do that in? So for instance, if you have a low risk of infection in a patient having a straightforward procedure, that may be a patient where it's not worth the incremental effort. But if you have a patient where the consequences of infection are much greater, then you will go to these simple measures to try to prevent infection. So a good example is a person having repeated procedures or having CRT. I think much of our community is going to err on the side of giving extra antibiotics in that situation. What I didn't talk about is we also looked at adverse events. And the adverse event rate was extraordinarily low. We had 50 adverse events in almost 20,000 patients. So there's almost no downside to administering the antibiotics in terms of causing harm. It wasn't greater. The adverse events were not greater in the incremental arm. And so as a result, the downside to doing this is the logistics of doing it, but we're not causing any harm by doing these things to try to prevent infection.